Well, thank you for having me. My name is Katie Smith. She introduced me, I am the clinical operations manager at SSM Health for the sports medicine service line, and also at our pediatric hospital, Cardinal Glennon Children's Hospital. And my team assists with much of the concussion triage that we do at our concussion clinic, with at Cardinal Glennon and in our adult ministries as well. So I'm going to kind of kick us off and kind of go through some of the common myths that we hear and that ultimately are still really talked about often. One thing I think is really important, specifically for the clinicians in the room, is when we're doing patient education, some of what we have to start off is sort of debunking some of those myths. Because ultimately we kind of have to level the playing field for some of that patient education. A lot of this information that's out there is dated information, but information that is still often talked about. And so we kind of have to start by leveling that playing field as far as that information to ensure that we're providing proper patient education. So a common myth that is out there is that a concussion occurs only with a direct blow to the head. And like Dr. Daniel just talked about, we actually know that that's incredibly a myth. Ultimately, actually more concussions happen without a direct blow to the head than with a blow to the head. And so while concussions can occur when you have a direct blow to the head, it's the coup and counter coup movement of the brain inside of our skull that's actually creating that concussion, not the blow itself. And so it's really important that when we talk about mechanisms of injury, or when we ask patients, hey, did you have an injury that occurred that then led to these symptoms, that we're asking more than just, did you get hit in the head? Often when we're especially talking to that middle school and high school population, we're asking that direct question. And ultimately they're going to sit and say, no, I didn't get hit in the head, but I got checked in the boards, right? And then I had that coup counter coup movement, and that's actually what caused that concussion, rather than, you know, taking a ball or someone directly hitting you in a head-to-head hit. So it's important that we ask those questions, knowing that over 90% of concussions actually don't have a direct blow to the head. Another common myth that we hear is you have to have a loss of consciousness in order to have a concussion. And again, that is very much a myth, and actually more concussions than not don't have a loss of consciousness. And a loss of consciousness doesn't necessarily actually create a timeline for a more severe concussion or a concussion that takes a longer period of time to recover. A loss of concussion can occur due to any type of mechanism, and doesn't necessarily mean that they are concussed, and doesn't necessarily mean that has to happen in order to be concussed. So this is a common grading scale that we often see. If you go online and Google types of concussions, these are often things that you're going to see. So the challenge with concussions is there's a variety of different grading scales for traumatic brain injuries. If you were to look online, or if you were to look in a variety of different journals. The challenge is there is no consistent grading scale for grading a traumatic brain injury. And ultimately, that is actually why we shy away from grading concussions completely, due to the sort of misinformation that it leads to. So there's sort of the misconception, if I sit and say you have a grade 1 concussion, that would mean that you're going to recover in a certain amount of time. And ultimately, that's the challenge of grading, is that just because you have these specific symptoms does not indicate the amount of time that it's going to take you to recover. And so we really stay away from grading. You either are diagnosed with concussion or you are not diagnosed with concussion. And then we looked at your symptom severity score, and then we treat you based on that and your clinical signs and symptoms, rather than stating, oh, you have X, Y, and Z. You didn't have a loss of consciousness, but you have confusion. So that's going to predict how you're going to do as far as recovery. That's just not really very accurate, unfortunately. And so we really want to shy away from that. You will see places that still use that, because there are journals out there that talk about grading traumatic brain injuries, but we really want to stay away from that when discussing concussions with patients, as well as with providers. So everyone is at the same risk for concussion. And so Dr. Daniel talked a little bit about this earlier. Ultimately, there's a variety of different things that we look at when we're talking about a risk for a concussion, right? So we know that if you look statistically speaking, females have a higher risk of concussion, specifically as it relates to females that are doing certain sports, like something like soccer, for example, which typically has one of your higher rates of concussions. But what we also want to be clear on is that once you've had a concussion, it's going to take less of a mechanism to produce concussion-like symptoms. And so that's also another factor. But what's also important to talk about when we talk about risk is those underlying risk factors that patients may have as far as recovery. So Dr. Daniel hit on this a little bit, right? So patients that have an underlying diagnosis or potentially not have a diagnosis of something like anxiety or depression or ADHD, or a vestibular underlying concussion, those patients are likely going to take longer to recover. And it's important that we note that and take a good medical history to ensure that we can really talk about what the recovery timeline is going to be, and also make sure that we're referring appropriately for that. So for example, with the question earlier that was asked about referring to a pediatrician, one of the things that we talk about often is that if a patient has an underlying condition such as like headaches or migraine, we typically are going to want to refer to a specialist more quickly, knowing that something like medication intervention is likely going to be necessary for that patient due to their underlying health condition. And so understanding things like that and understanding, for example, like ADHD, if a pediatrician is managing their ADHD already and they're comfortable managing concussions, that would be a great provider because they're already managing that condition. Or if they're seeing a neurologist, for example, for migraines, that would also be an appropriate provider because of their underlying condition. So understanding some of those underlying risks of patients can really help us come up with an appropriate treatment plan and provide that intervention much more quickly and ensure that they can recover as quickly as possible. So another myth is that it's safe for a player to return in the same game or practice after experiencing concussion-related symptoms. And that is absolutely a myth, right? So if we're unsure if they had a mechanism that could elicit those symptoms, or if we're unsure if they have concussion-like symptoms, we want to pull that athlete from participation, take at least 24 hours to reevaluate that patient, and then make a diagnosis at that time. Ultimately, some things act very much like concussion symptoms. One of the most common things we see as an athletic trainer like myself is things like heat illness presenting like concussion. So a patient is out on the soccer field. They have a mechanism where they did have a coup or counter coup mechanism of injury, but some of their symptoms also mimic sort of some type of heat illness. So confusion, dizziness, balance issues, things of that nature, even headache, also can be associated to heat, right? And if it is 95 degrees outside, that can absolutely be a factor. And so we want to pull them from play, stating that they do have those symptoms, and reevaluate them in 24 hours to try to better evaluate at that point in time if there were other factors that were associated with those symptoms, or if in fact they do have a concussion and we treat them accordingly for that. So we would always want to err on the side of caution due to things like second impact syndrome, is to pull them out of play and reevaluate them at that point in time. While it's frustrating for student and athletes sometimes and for parents, clinically is absolutely the appropriate thing to do. A concussion treatments and recoveries are all alike. I kind of hit on this a little bit earlier, but no two concussions are alike. And I think that's really important that we talk to patients about that. Often patients are going to try to find a friend who's had a concussion and, oh, well, my friend Johnny had a concussion last year and he was back in 5 days. So that's what it's going to be for me, right? And it's really important to educate our patients, but also the patient's parents about realistic expectations. And the fact is that we treat each patient and each concussion separately and uniquely, right? We have to look at their symptom presentation, their symptom severity score, as well as that cognitive and vestibular functions in order to ensure that we're making the right decision for that specific patient for that specific concussion. Even patients with a previous concussion, they can actually present significantly different. Ultimately, we do see patients who have had a previous concussion. Often their symptom severity score is going to be higher that second time, just because they've had that previous injury. Not always, but every patient's different, and we need to make sure that we're treating each concussion uniquely and independently. So we talked about this in the last presentation as well. There's still sort of this old myth. You'll talk to a lot of coaches, especially, and even a lot of parents say, okay, my child has a concussion. We need to go put them in a dark room. They can't talk to anybody. They can't do anything. It's what we used to call cocoon therapy. So literally being just in a quiet room for days on end, and that's what's going to make them better. And actually, we're recommending quite the opposite of that. We want them to have time with friends, because from a mental health perspective, that's incredibly important. But we also want that light aerobic activity really within that 24 to 48 hours post-injury, as long as it's not increasing their symptoms. And so it's been shown to be significantly impactful as far as that recovery time for the patient. patient. And what we see when we do something like a SCAT-5 or a symptom score, usually once we introduce that light aerobic activity, we see a dramatic increase in that symptom severity score, which is what we're looking for, right? And then often patients are going to be left with maybe 1 to 2 symptoms that are still lingering that then we're working through to ensure that we can work through those symptoms to get them symptom-free so we can start a return to play protocol. But really introducing that light aerobic activity is incredibly important. We need to be clear on recommending that, right? We're not returning them to play in any way, shape, or form. We're just making sure that they are independently doing an activity that has a slight increase in heart rate, increasing that blood flow to the brain, that has really positive implications as far as recovery. But we do want to be sure that we're in the age of technology, being realistic about screen time with our student athletes as well, right? So it is not realistic to completely eliminate screen time for, let's say, our high school and middle school population often, right? But can we significantly decrease that screen time? Absolutely. For student athletes that are in school that use things like Chromebooks and have a lot of additional screen time, at that point, we'll recommend using just a hard book. Paper is much less demanding for your eyes than something like a screen. That light reflecting is going to be much more demanding. And so we can make those changes without completely eliminating it, right? So they may not need to play video games for 4 hours that night, right? But if they need to text their friend or call mom, that's fine for them to look at their phone. We just want to decrease the amount of demand on our brain rather than doing nothing per se. We would certainly encourage a kid to spend time with their friend versus sitting on the phone and texting or playing a video game, right? Because that interaction is positive and has a low brain demand versus something like a video game for, again, 2 to 4 hours, that would be quite demanding on the brain. Having 1 concussion places you at an increased risk for future concussions. And so that's sort of a yes and no, right? So what it does is it puts you at an increased risk for what we could consider a sub-concussion mechanism to create those concussion-like symptoms. And so what we see with people who have had multiple concussions is it takes very little mechanism to reproduce those symptoms, which can then lead them sort of more predisposed to concussions in that, because it just takes less for them to have that symptom presentation. And so that's a really key factor that we want to think about. But again, also looking at what other parts of their medical history would lead them sort of predetermined to that, but also what type of activities are we doing? So when we talk to patients who at a young age have had 2 or 3 concussions relatively close together, one of the things that we talk about are what are you doing risk-wise to put yourself in a position to get a concussion? So for example, something like soccer or football has a very high incidence of concussion rate, whereas something like track or another activity that has less direct hitting or touching would certainly be less risky. And so sometimes we have to have those conversations with patients. Is it going to completely eliminate the risk? No, I can trip over this, this stool here and I can fall and get a concussion, right? You can have it any time, but there are certain things that are more risky than others, especially with, again, that coup and counter coup movement, that we want to ensure that we're putting them in a position to where the risk is as low as possible once they've had, again, 1 or 2 concussions. Definitely leads us to a challenging situation. Again, you think of people who've played in the NFL, right? And if by the NFL stage they've had 4 or 5 concussions, now they're in a very risky environment for that to happen again, ultimately, because we just know the risk is higher. So that's often when we're recommending, hey, it's not that you can't do anything, but let's really reassess what makes sense for you as an athlete. Concussions definitively cause long-term brain damage like chronic traumatic encephalopathy, or what's known as CTE. And so ultimately, we don't really know yet. CTE research is incredibly new still. The challenge of CTE is that we can't diagnose it on a living person. The person has to be deceased in order to evaluate the brain and those tau proteins. And so we don't know. Ultimately, what we know is that CTE is due to repetitive brain trauma, but we don't know if that's due to concussions that have not quite healed, and then we have additional concussions. We don't know if that's over a certain period of time or during certain developmental periods of time. We don't know what other risk factors would make that more prominent, like family history of something like dementia or other brain-related illnesses. We don't know. We don't have enough people diagnosed. But certainly it's logical to believe that any type of repetitive brain trauma is obviously going to negatively impact a patient. And so when we talk about concussions, they are separate of CT. They are not the same thing, but it's important to educate patients on managing concussion fully and making sure that they're fully healed before we're turning them into an activity in which they have a high risk of sustaining another concussion, because we do know for things like second impact syndrome, that is directly related. We have research that backs that. Hopefully after a period of time, we'll have better research on CT, but specifically until we can get better data on CT when a patient's living, that's going to be quite challenging to make those direct correlations at this point in time. And we certainly just need more data related to that. Helmets and mouth guards can prevent concussion. This is one we hear way too often, right? So helmets are meant to prevent skull fractures. They are not meant to prevent concussions, right? So what we talked about a minute ago, that coop and counter coop movement is an egg in a jar, right? Just if we put padding on top of that jar, the egg can still move in water in a jar, right? That doesn't change that, right? That's just changing something hitting and breaking the glass, okay? That's always the analogy I give patients to help them understand that movement of your brain inside of your skull. Since they don't feel their brain move, that's sort of hard to conceptualize for kids, but your brain is moving. It's supposed to move. That's okay. It's meant to have some movement there, but that brain hitting against our skull and having those changes occur inside of our brain is really what's producing those symptoms. The helmet doesn't change that. Ultimately, things that can benefit us are things like neck strengthening exercises to control our neck, and also core strength. So our body's ability to control our body will decrease our risk of concussion ultimately. And that's ultimately where we look in the younger population when they have poor body control. They're absolutely susceptible to these types of head injuries because they have poor body control, which is going to naturally make that coop and counter coop movement happen when they get pushed or shoved and then either hit something or just have that mechanism isolated outside of hitting something additionally. So something that's important to just remember. Mouth guards, same thing. That's not going to change that movement in your brain. The mouth guard is there to protect your teeth from any damage of getting hit with anything. We'll obviously see that in sports. We're going to have a direct blow to the mouth, but that's not going to change any of the factors as far as your brain moving inside of your skull, if that makes sense.